Thank you. Okay, good evening all. Let me begin by introducing myself. I'm Dr. Nsuya Naidu. I'm an adult neurologist based in Durban in South Africa. And I'm basically speaking from a very chilly Durban. It's hit a low of 8 degrees here this evening, which is very unusual for Durban. So thank you to everybody who's joining us from across the continent. And if we have anybody joining us from further afield as well. So without further ado, our topic for this evening is on dietary therapies in children with drug-resistant epilepsy in low middle income countries. And we are very lucky to have an esteemed speaker who will be talking to us this evening, and that is Dr. Pauline Samir. So I'm just going to give you a brief introduction to Dr. Samir before we proceed. Dr. Samir is a pediatric neurologist based in Nairobi. She's an associate professor and chair of the Department of Pediatrics and Child Health at Aga Khan University Medical College in East Africa. She holds a master's in philosophy in pediatric neurology from the University of Cape Town in South Africa. And she is responsible for the training on the residency program in the department at the university, as well as the administration and provision of clinical services at the university. Dr. Samir has a long-held research interest in pediatric neurology conditions, which are prevalent in the local Kenyan setting. She has led research projects in epilepsy, attention deficit hyperactivity disorder, autism spectrum disorder, and cerebral palsy. Her research interests include improving the understanding of biopsychosocial contributors to preterm births, including adverse childhood experiences, with the aim to identify preventable causes of child neurodisability. Dr. Samir has participated in several grant applications with publications in peer-reviewed journals as well. She has supervised pediatric master's students and reviewed many dissertation projects in her capacity. Dr. Samir participates in the department mentorship program and has been at the forefront of advocacy for further subspecialty training for her residents. And as a result of her efforts, 7 other Kenyan female pediatricians have been accepted into training as pediatric neurologists, which I think we can all agree is a formidable feat. So without further ado, I'm going to hand over to Dr. Samir. We look forward to hearing from you.
Hello, everyone. Today we will discuss dietary therapies for children with drug-resistant epilepsy in low and middle-income countries. My name is Pauline Samir. I'm an associate professor and a pediatric neurologist at Aga Khan University, East Africa. So we'll first look at epilepsy in low and middle-income countries. So the burden of epilepsy is larger in low and middle-income countries. And this is as a result of infectious etiologies, as well as multiple preventable causes. For instance, neonatal sepsis, birth asphyxia, and avoidable head injuries. So over 69 million people worldwide have epilepsy. And within this population, 62 million live in resource-poor countries. Over 90% of people with epilepsy in resource-poor countries do not receive appropriate care for their condition. Over 80% of epilepsy-related deaths have also been documented in low and middle-income countries. So this is a map that shows this age-standardized prevalence per 100,000 of idiopathic epilepsy for both sexes from a study conducted in 2016. So in general, the red areas have a higher prevalence. And you can see that those are the areas where we have the low and middle income countries predominantly, For instance, in the deep red areas, you can see the prevalence ranges from 630 to 680 per 100,000. Whereas in the darker blue areas, this ranges from 130 to 180 per 100,000 population. So drug-resistant epilepsy is defined as the ongoing epileptic seizures accompanied by neurobiological changes, cognitive decline, and psychosocial dysfunction. So symptoms tend to persist despite the administration of two appropriate anti-seizure medications utilized either as monotherapy or in combination. Approximately 1/3 of children with epilepsy have clinical syndromes characterized by drug resistance. A wide variation in the prevalence of drug-resistant epilepsy has been observed worldwide, ranging from 6 to 69%, depending on the methodology utilized, as well as the case definition of drug-resistant epilepsy. However, this diagnosis portends a poor outcome in general for the patient due to the association with premature mortality, various comorbidities, social implications, and overall a poorer quality of life. So the epilepsy treatment gap, this refers to the number of people known to have epilepsy but not yet receiving appropriate and effective treatment. So this treatment gap has been documented to exceed 80% in some rural parts of Kenya. And this is due to stigma and lack of public awareness in some cases, and availability of appropriate anti-seizure medications, as well as financial incapacity that hampers access to health services. So utilization of dietary therapies has been proposed as an intervention that could aid in the closure of the epilepsy treatment gap. So this is a map that shows differences in prevalence, incidence, and the treatment gap in various countries. So once again, the more red the area, the higher the treatment gap. For example, in Tanzania, it has been recorded to as high as 95%. In India, you can see a treatment gap documented of 75%, whereas in the United States, this is only 7% and 3% in Norway. So the better resourced an area is, the less likely it is that an epilepsy treatment gap will be documented. So we do need solutions to end this epilepsy treatment gap. And we know that there are interventions such as epilepsy surgery and vagal nerve stimulation, and these tend to be more readily available in the high-income countries, but at present, they are unlikely to be consistently available in the low and middle-income countries due to cost, manpower, skills, and various other factors that contribute to lack of availability. At the same time, advocacy efforts to lobby for effective initial treatment and treatment alternatives for this group of patients are frequently limited by cost implications as well as lack of data. So to this end, exploration of potentially scalable interventions for drug-resistant epilepsy becomes a pertinent and urgent issue. So what are the dietary therapies for epilepsy? So we will start with the classic ketogenic diet, which is a high-fat, adequate protein, and low-carbohydrate diet that is used to treat drug-resistant epilepsy in children. At the present time, it is being explored for various other uses as well. So the diet leads the body to burn fats rather than carbohydrates, leading to the production of ketone bodies, which are then utilized by the brain as a source of energy. The classic ketogenic diet provides just enough protein for body growth and repair, and sufficient calories to maintain the correct weight for age and height. The classic therapeutic ketogenic diet was developed for treatment of pediatric epilepsy in the 1920s But because of development of effective anti-seizure medications, then it fell out of use until formal studies were commenced again in 1994 at the Johns Hopkins University. So by 2007, the ketogenic diet was available from approximately 75 centers in 45 different countries, predominantly in the high-income regions. Then came the modified Atkins diet, and this diet mainly restricts daily carbohydrate consumption to 10 to 20 grams per day. And it has also been utilized to treat intractable seizures in children and adults effectively. It was again first utilized in 2003 at the Johns Hopkins University. And the diet allows adequate calories and proteins for growth and does not require fasting as an inpatient for initiation. I must just mention that Atkins is a proprietary name, and therefore currently it's thought that it's better to just designate these diets as the modified ketogenic diets. So the third form is the low glycemic index treatment diet. And this is, again, a lot less restrictive compared to the modified Atkins and the classic ketogenic diet. And it allows for 40 to 60 grams of carbohydrates per day. But these carbohydrates are restricted to food items which have a glycemic index of less than 50. For example, soy products, beans, fruits, and oats, meaning the children are still not allowed to take in things like bread and porridge, which are commonly used in Africa. I'd like to highlight one study that was conducted in India and published last year in August 2020 and sought to establish the non-inferiority of the modified Atkins diet and the low glycemic index therapy diet in comparison to the classic ketogenic diet. So whereas this non-inferiority was not proven, the median reduction in the seizure frequency among the 158 children who were randomly assigned to either of the groups was generally the same. There was no statistically significant difference in the effectiveness of the ketogenic diet, the modified Atkins diet, and the low glycemic index therapy diet when the different groups were compared. So you can use either depending upon the tolerability and availability for each child. Only that for children under 2 years of age, the ketogenic diet in the classic form is definitely superior. So once again, we're looking at maps that show the distribution of the availability of dietary therapies across the world over 10 years. So the first map was published in 2005, and you can see apart from South Africa, in Africa, there was no other country that was availing the dietary therapies. Then in 2015, we can now see Uganda and Egypt and Tunisia providing the diet, but overall, there was very little change over that decade. So we would like to have dietary therapies availed to children who need them because they are efficacious for drug-resistant epilepsy. So a growing body of evidence adduced from many parts of the world indicates that dietary therapies are efficacious when offered to children with drug-resistant epilepsy, leading to a reduction in the number of seizures reported. As mentioned earlier, the classic ketogenic diet shows high efficacy in children under 2 years when compared to the modified ketogenic diet. So I'd like to highlight one study where, on comparison, for sure there was a difference in the baseline number of seizures among those who had the ketogenic diet compared to the modified Atkins diet group, but this difference was not statistically significant. However, for patients aged 1 to 2 years, the mean and the median seizure frequencies in the ketogenic diet group were significantly lower. The complication of hypercalciuria was presented or reported more frequently in the KD group compared to the modified Atkins diet group, and this was a statistically significant difference. So the modified Atkins diet or the modified ketogenic diet therapy might be considered as a primary choice for treatment, but the classic ketogenic diet is definitely more suitable as the first line of therapy for patients under 2 years of age, according to this study. So regarding the economic viability of the ketogenic diet, this is definitely an ongoing challenge because this diet has had a negative evaluation regarding its economic viability in a systematic review of economic evaluations of treatments for patients with epilepsy, especially in low and middle-income countries. This means that the ketogenic diet is more costly to implement in low and middle-income countries, therefore putting it out of reach for the majority of the populations. The International League Against Epilepsy has put together minimum requirements for implementing the ketogenic diet program, even in a resource-limited setting. However, when you critically evaluate this list, you notice that some of this, or quite a number of these requirements are pretty difficult to obtain, even in the low and middle income countries. For example, just maintaining a calorie count, a 3-day food record. This might be challenging in various parts because of problems with literacy and understanding. When you consider the basic minimum liver tests, such as the liver function tests, especially so in patients who are receiving hepatically metabolized anticonvulsants, this is not uniformly available. It tends to be costly and may not be met by many patients. Even where you have optional tests, such as determining carnitine, selenium, and magnesium levels, these are difficult to obtain in most of the areas where we practice in sub-Saharan Africa. Regarding tolerability of the KD, intolerability or the restrictive nature of the ketogenic diet was noted to account for a 35% dropout rate, despite reporting a greater than 50% reduction in seizures in an Egyptian cohort. This means that the families found it difficult to adhere to the ketogenic diet, despite the fact that it was actually effective for their children. So in this same study, the patients were then moved over to the modified ketogenic diet. And this, at 9 months of implementation, led to significant improvement in the growth and seizure control in the patients who had intractable epilepsy, as well as a significant improvement in the quality of life of their mothers, who were the primary caregivers. So experts across the board agree that the role of the alternative diets remains to be explored further, and thus constitutes a priority need for research, with the potential for utilizing the modified ketogenic diets as well as the low glycemic diets in poorly resourced countries yet to be determined. So diets vary widely in sub-Saharan Africa. Though they are described to be predominantly starch-based in most regions, combinations utilizing available options to induce ketosis have been successfully utilized. For example, in Uganda, locally available fish and kidney beans were incorporated into a feasible diet with ketosis achieved successfully, with reduction in seizure control among the children at one of the homes where this was utilized. So simpler diets utilizing locally available dietary options may have wider acceptability and practical utility for children with drug-resistant epilepsy residing in low and middle-income countries. However, these approaches have not been consistently studied, and effort needs to be put into this. So why should we use the modified ketogenic dietary therapies? These are simply simpler to implement compared to the classic KD. There's no need for fasting, and can be started as outpatient on an outpatient basis. We are sure that these diets are efficacious. For example, a randomized controlled trial which compared children who are on the modified Atkins diet and anti-seizure medications compared those on the diet to those who are on standard medical therapy with no dietary intervention. And this study found a statistically significant reduction in seizure frequency compared to baseline among those who are on the modified ketogenic dietary therapy after just 3 months of utilization. The proportion of children who had greater than 90% seizure frequency reduction in the seizure frequency, as well as those who had a greater than 50% seizure reduction, was significantly higher in the diet group compared to the group that just had care as usual. So the efficacy of the modified ketogenic diet at 3 and 6 months post-diet has proven to be successful, usually with greater than 50% of the patients achieving greater than 50% reduction in the baseline seizure frequency, which of course is significant for children. So we also know that the modified ketogenic diet therapy allows for flexibility. For example, in a Danish study that was carried out in 2010, the authors sought to compare the efficacy and the tolerability of the ketogenic diet compared to the modified Atkins diet, and concluded that the modified Atkins diet was similarly effective as the ketogenic diet in reducing seizure frequency in children with medically resistant epilepsy. However, the study also reported that the most effective seizure control was attained using a patient-tailored diet, where families worked independently to find the most appropriate level of fat intake and ketosis for their child. So this level of flexibility resulted in greater than 90% seizure freedom, as well as better compliance for those families. Why we should also consider the modified ketogenic dietary therapies is because fewer complications have been reported in patients on the modified Atkins diet compared to the classic ketogenic diet, although the efficacy of both diets is similar. So the most common reasons for discontinuing this diet were food refusal and the perception that the diet had become burdensome. We know that the modified ketogenic diets have also been adapted for parental literacy levels. For example, Sharma and colleagues took into consideration the literacy levels of parents in northern India and substituted measures such as cups and spoons instead of having to weigh in grams to help them implement the diet, and this was successful. There has also been publications that show that telehealth and email have been successfully utilized to assist in the modified ketogenic diet implementation in areas such as Honduras. So where dietitian or physician support is limited for patients with epilepsy, remote access via telemedicine could certainly provide an alternative. So a feasibility study was conducted to investigate the tolerability and efficacy of the modified Atkins diet administered solely via emails to adults with pharmacoresistant epilepsy, but who had limited access to this therapy because of lack of availability of a dietitian or nutritional support, or even lack of familiarity with the diet by their treating neurologist. So email administration of the modified Atkins diet to adults who had refractory epilepsy was found to be feasible and effective. So these findings can be extrapolated into settings where now mobile phone coverage is definitely improving in sub-Saharan Africa. At this time, we also have movement restrictions occasioned by the current pandemic, and therefore remotely supported resources therefore offer another avenue for improved access for epilepsy care. I'd like to highlight a study that was a qualitative exploration into the acceptability and feasibility of the modified ketogenic dietary therapies. So in-depth interviews were held for 14 parents and 3 adolescents who had utilized the modified ketogenic dietary therapy at a tertiary center in Nairobi in 2020. That's when the study was conducted. So the caregivers were predominantly trained professionals who are living in urban areas, although some lived in the rural areas. And they had attended the epilepsy clinic anything between 1 to 14 years. The duration of use of the modified ketogenic dietary therapies ranged from 2 weeks to 2 years. And at the time of the study in 2020, only 3 caregivers were still administering the diet. 8 of them reported barriers to using the modified ketogenic dietary therapy, including the cost of the food, child refusal of the foods, as well as inconsistent dietitian support. So the cost of food required to implement the modified ketogenic dietary therapy was cheaper for younger children and for those living in rural areas in this study. Family and social support were key enablers to successful implementation and continuation of the diet. And 10 of the 14 caregivers and 2 of the 3 adolescents considered modified ketogenic diets to be an effective and acceptable intervention for the management of epilepsy. Greater satisfaction with modified ketogenic dietary therapy was more likely to be reported by caregivers who experienced reduction in seizures in their child. 3 children became seizure-free on the diet and were continuing it at the time of the study. 10 caregivers, as reported, said they were satisfied with the modified ketogenic dietary therapy despite observed negative effects such as constipation and weight loss, or even undesired weight gain. They considered dietary measures as safer and more acceptable than anti-seizure medications. Of course, dietary therapies are not without risk. So in summary, the burden of epilepsy is larger in low and middle-income countries. And despite availability of newer and more efficacious anti-seizure medications, at least 1/3 of children with epilepsy have drug-resistant symptoms. A large treatment gap for epilepsy exists in many countries in low and middle-income countries, and there is the need for implementation of other viable therapeutic options. Modified ketogenic dietary therapies are efficacious, safer, and easier to implement compared to classic ketogenic diet. So in a study conducted in Kenya in 2020, the modified ketogenic dietary therapies were found to be feasible, efficacious, and acceptable to a cohort of patients. Social support and dietitian support were considered important for successful implementation. So those were my references. And thank you very much for your attention.
Thank you so much, Dr. Samir, for a very informative and interesting talk. I think there is little doubt that the ketogenic diet and the modified ketogenic diet is efficacious, but I think there are certainly problems around implementation of the diet, as well as challenges in terms of barriers to implementing the diet, even in well-resourced countries. And I think you covered quite a few of those barriers. So I'm going to move on to questions. And we have 2 questions already on the chat. If there are further questions, you can either post it on the Q&A chat, or you can raise your hand to ask the question live. So the first question, Dr. Samir, if you are ready to respond, is from Dr. Albazi. And the question from the doctor is that, do you recommend carbohydrate restriction in epileptics, even if they are not resistant? However, they are on more than one anti-epileptic drug.
Okay, thank you for that question. Restricting carbohydrates is a process that one would need to go through carefully. And generally speaking, not unless the child is continuing to have seizures on these 2 anti-epileptic or anti-seizure medications, there really is no indication. So where a child is still responding to anti-seizure medication, then the risks outweigh the benefit. Remember, this is therapy just like any other, and it does carry with it certain risks. And it probably would be better that children respond to anti-seizure medications and don't need to move on to such interventions. So it's not recommended unless they have failed more than 2 medications given consecutively or together.
Okay, thank you for that. So I'm just going to Dr. Dennis would like to respond to this question live. Jessica, can you assist me with that? I'm not sure how to allow the participant to answer live.
You can just continue and ask the questions. We just mark the questions off as they appear.
Okay, no problem. The next question, Dr. Samir, is again from Dr. Albazi. Are there foods or food additives that should be used cautiously in epileptics?
First and foremost, I think that people who live with seizure disorders, we just call them people who live with seizure disorders rather than terming them as epileptics, because their lives and the disease are 2 different things. About foods and food additives, really, not really. We try not to restrict the lives of people who live with seizure disorders as much as possible, unless something is hazardous to them. For example, if you're having a photosensitive epilepsy and you want to go on to a disco and it might endanger your life, generally we try not to restrict. So I wouldn't say that there are really any food additives or foods that we would use cautiously. I think you should allow people living with epilepsy to live as full a life as possible, take their anti-seizure medications, keep their appointments, and maintain a healthy balance to their lives.
Thank you for that, Dr. Samir. I think if I can add to that, I think this form of therapy is a specific directed therapy rather than something that can be generalized to say avoid certain types of food or eat more of a particular type of food. That answers that question. The next question we have is from Dr. Al-Jandil. I hope I pronounced that correctly. And the question is, what is the percentage of seizure freedom? I would assume that's in relation to the modified ketogenic diet.
Okay, I would just say that it varies from child to child. And children who have genetic basis to their epilepsy tend to have a better response to the modified or even the ketogenic dietary therapies. So in general, where we've had study conditions, you find that at least 50% of the children get a reduction of at least 50% of their seizures reduced, or they get a reduction of at least 50% of their seizures. There are a few who will get absolutely no benefit, and some of whom cannot tolerate the intervention and therefore cannot continue it. But in general, that is what is observed. We have children, about 20 to 30% of whom will get complete seizure freedom, and therefore those ones are very enthusiastic to continue with their dietary therapies. I would say it varies from child to child, and children who have brain lesions, or rather symptomatic epilepsy as we would call it previously, are less likely to have complete seizure freedom on the diet. The other thing that's very helpful for the children on the diet, which we see in clinic all the time, is that their behavior and cognitive function tends to improve. So like this morning, we had a child who, despite the fact that he's still getting 1 seizure a month, he's a lot more chilled, he's a lot more controlled, and so the parents are enjoying being with the child a lot more.
Okay, thank you. Dr. Al-Jandil also has a question with regard to whether there is weight gain that is seen at times, and if so, if weight gain is noted, when is it seen?
Yes, it's one of those things that parents don't like to see, but usually it just means that the diet is probably it's not being followed as it should with carbohydrate restriction. If you take too much protein, that protein will then be converted into carbohydrates and therefore then stored, as fat in the body. So usually it just means that their family is probably compensating with too much protein, or the restriction of carbohydrate is not going the way it should. Under normal circumstances, when the diet is appropriately applied, we find that there is no weight gain or there's even some weight loss. That's the usual.
Okay, thank you. Professor Arif Hereka has asked if you have tried the ketogenic diet or the modified Atkins diet, modified ketogenic diet, in the Lennox-Gastaut syndrome. If you can just let us know what your experience is with that.
Thank you for that very interesting question. Actually, our patients with Lennox-Gastaut syndrome were the reason why we felt very strongly that we needed to start this therapy, because these are children who definitely will have failed multiple anti-seizure medications. So the answer is yes. Just like other countries in sub-Saharan Africa, despite the fact that the centers we practice in, people may have access to better resources, it is difficult to institute the classic ketogenic diet. So all our patients have been on the modified ketogenic dietary therapy with varying degrees of success, the vast majority of whom have benefited in one way or the other. So the answer is yes.
Thank you.
And to answer the next question, I can see, does it take the place of anti-seizure medications? The answer is really yes. No. It's actually an add-on. Yeah. Most of the times it's an add-on. They don't go completely off medications. Once in a while, we're able to reduce doses and probably move from 3 medications to 2. But no, we wouldn't say it actually does take the place of anti-seizure medications.
Okay. Dr. McLaren has asked if there is a reason for better efficacy of the ketogenic diet in children under 2, or is it maybe just because it is easier to control what younger children eat, or is there a physiological explanation for it? Your thoughts on that?
It's actually both. Thank you for that question. So the classic ketogenic diet, as you can imagine, the amount of fat to both protein and carbohydrate combined is 1 to 4, of basically 4 to 1. And so it has got a lot of fat. And so it is easier to give this kind of diet to a younger child who hasn't yet probably developed taste preferences. And especially so also in PEG-fed children who have, gastrostomy tube in situ. And then it's also thought that physiologic reasons also contribute. The rate of metabolism and how they metabolize food makes it easier, or rather for them to attain seizure freedom using the ketogenic diet. So yes, you're correct. The physiological reasons and also the fact that a younger child is easier to train in a certain way. Also, we know that there are some children who have a preference for a diet that has more fat. We've seen that even, among our children with living with epilepsy.
Okay, thank you. Dr. Al-Jalal has asked until which age this diet is effective.
At this point in time, the modified ketogenic dietary therapies are easier to institute in children who are older. And we know of randomized controlled trials that have been done in both children and adults, and it actually has been shown to be beneficial even in adults. So we really can't talk about an age limit. It's just that for some reason it gets less and less efficacious the older your patient is.
Yeah, if I can add to that, I think the studies that have been done are uncontrolled studies in adults, but it's shown similar response rates with seizure reduction to children. But there's clearly a need for controlled studies in the adult population. So I don't think it's something that should be ruled out in adult refractory epileptics. Something that needs to be investigated. Okay. Dr. Asukile has asked if there is any role for the ketogenic diet in older children or adults with seizure onset in infancy. I think you might have covered a bit of that, but I'll let you respond.
Yes, Dr. Asukile, there is a role for ketogenic diet in older children and adults with seizures with a childhood onset. And even if it is not a childhood onset, it can be trialed where it's indicated. Remember, we tend to use the ketogenic dietary therapies where somebody has failed 2 or more anti-seizure medications. So really, it's not your first choice. It's not your first choice for treatment. Remember, it carries risks. I know of people who aren't even on anti-seizure medications, but for weight control, prefer to use the modified Atkins diet, so to speak, for weight control. And when you use it for a long time, you put yourself at risk for renal stones. These are things we have seen. So you can get renal stones, hypercalciuria, if not even hypercholesterolemia, although this in children tends to resolve within the first 6 months. Some children become weak when they put on the diet. They may vomit, may have constipation. Constipation tends to be another long-term problem. So this dietary therapy is not without its own risks. So in the same way we're careful with the dosing of the anti-seizure medications, we are also careful with initiation, control, and maintenance of a modified ketogenic diet as well, or even the ketogenic diet as well. And we tend to find more complications with the ketogenic diet compared to the modified forms of the same.
Okay, thank you. And Dr. Parbu has asked if you have used the modified ketogenic diet in children with tuberous sclerosis complex and DRE.
Certainly, for drug-resistant epilepsy, that is the focus of the use of the modified ketogenic diet. Among our cohort, we have a number of children with tuberous sclerosis, but I think that for this group of children, the fact that we probably put them on vigabatrin very early and then move them on to clobazam, the vast majority have well-controlled seizures. So I do not recall a child with tuberous sclerosis complex who's also on the diet, but if they did have drug-resistant epilepsy, we would offer them the opportunity.
Okay, thank you for that. I think for now, those are all the questions we have on the Q&A chat. We have a few more minutes if anybody else would like to ask a question either live or on the chat. But in the interim, Dr. Samir, if maybe I could just engage you in a little bit of discussion. I think like you had discussed, implementing this diet can be challenging. You dealing with children who want to eat what their friends are eating, or even if they are kiddies with neuropsychiatric problems and they may have dietary preferences, can be difficult to implement. And I think the other stumbling blocks with regard to this diet is preparation of the meal, particularly if both parents are working, cost of the products, and obviously local dietary preferences, which I think across Africa is largely carbohydrate based. So do you have any advice in which you could encourage parents or support caregivers to implement and persist with the diet?
I think that our audience today is mostly the healthcare workers. And so my advice would be to them. And well, yes, if I got an opportunity, I would like to speak to parents as well. So I'd like to talk a little bit more about the study that we just, we concluded sometime in 2020, the end of 2020. Why? Because it actually addressed all those things that you talk about. It was a qualitative exploration. And therefore, when you do something like that, then the parents, the interviewer, and they say all sorts of things. They are free to express themselves. So for example, we found that single parents actually struggled a lot more than parents where there were 2 people involved in the therapy. Why? Because when you're two of you, then sourcing, costs are shared, you encourage one another. And of course, when you're thinking about a couple, a family, you know, a family that has two people in it, there tends to be a wider support network around them. So that was one thing. The other thing about cost, it was interesting that people found that if you went to the local market vis-a-vis going to the supermarket, of course, it was cheaper to go into the local market. And then again, the parents who felt that they could continue the dietary therapy for long were those who are living in the rural areas. The cost of food for younger children and for parents who are domiciled in the rural areas, which in a way is good because approximately half to about 2/3 of our own population currently lives in rural areas. And that's what we think that we should try very much to scale up the use of dietary therapies, because if that's where the food is cheaper and these components are actually available, so that's a good thing for our population. So the cost was relative. About the time taken, yes, we had one parent who actually stopped working to be able to institute the diet. So she was lucky because her child has a genetic basis for his epilepsy, does not require surgery, has a normal MRI. And so it was quite emotional for her during the interview because she had to give up. She's an accountant by training and had even trained as a financial analyst, her husband is a pharmacist. So she decided to stop working, and luckily for them, the diet did work. And so they are continuing it. He's a bit shorter than his brother and sister. He's one of a set of triplets. So yes, these are sacrifices that parents have had to make. And of course, it's easier to continue where you see a positive effect for your child. So their study was quite eye-opening for us. And the last thing that was also helpful was for parents who joined or who are engaged in support groups, like WhatsApp groups where they could talk to other parents who were undergoing the same thing. They tended to do better than parents who were just trying this on their own. So I know that's quite a bit of a mouthful, but the study that we did, which we are just about to submit, was an eye-opener for us.
Okay.
Yep.
And in terms of the actual side effects of the diet, you'd mentioned constipation is a problem, as well as dyslipidemia, which tends to be transient. The dietitians could probably address better, but I'll ask it nonetheless. Would increasing dietary fiber with use of fruit and vegetables be something that's feasible without markedly affecting the ketosis levels that the diet induces?
I hear you. Yes, it's true that increasing dietary fiber would help. And I think that's part of the reason why those patients who in India, when they were studied, were on the low glycemic index treatment, I think they did better. They were able to use the diet for longer. Why? Because they probably had more options and could include more fiber in their diet. So yes, it's true. That's one way. What I know is that for us, we would put them on Dufalac. I sorry, I use the brand name, but basically that's what I remember it as all the time because it tends to work well for our patients. So basically, stool softeners and osmotic laxatives would be some of the things that you can prescribe to help overcome that problem. But yes, it is a serious problem. It happens quite frequently. And the other thing that I found that interesting from our study was that the International League Against Epilepsy, they had this group of experts who put together a set of minimum requirements for a center to be able, or for a unit to be able to institute the ketogenic diet. And they did not think that having a dietitian, especially so for the modified ketogenic dietary therapies, was an important thing. But our parents felt that no, you really truly do need a dietitian to hold your hand as you continue with or institute the diet. So it's been an eye-opener that truly we do need our dietitians to help these families and to be available, even if it's just the modified forms of the diet that is being instituted.
sure, for sure.
Yep. Yep.
Well, thank you so much for that. We have no further questions on the chat, and our time is almost up. I just have one more very maybe brief discussion point. Is there's clearly a need for refined or simpler formulations of the diet. The diet clearly works, but would probably benefit from simpler formulations. And in the adult population, there's been some talk of the medium chain triglyceride diet being used, which can actually replicate the efficacy of the ketogenic diet. Your thoughts on that? Yeah, I don't know if you have any comments with regard to that.
I hear you. We too have not formally studied this, but we most probably need to. And it could be quite easy because one of the MCTs that's easily available in our locale is coconut oil. It's an MCT-based oil. It contains mostly MCT. And so I think it's feasible. I think even in South Africa and quite a number of countries, coconut is easily available. Yeah. So I agree. It's one of those things that we could try. And I think that even 50% seizure reduction is a very good sort of outcome. For example, if a child was having 3 seizures in a week and it goes down to 1 seizure in a week, I think that is really helpful. Or if you're having 4 seizures in a month, because it's not that the anti-seizure medications don't do anything at all. It's just that this child doesn't attain complete seizure freedom, which is really the aim during treatment. Of course, within limits, you do not want to have unacceptable side effects. So that's what it means to have 50% seizure reduction. And we need to trial it on very many patients because there is a proportion that will become completely seizure-free. For this study that we did, we only interviewed 17 people, basically 14 adults and 3 children. And out of that group, 3 of them were completely seizure-free and were continuing to use the diet. So we still think that we should just avail it better across the country. And yes, I like the idea that we probably should study the MCT-based diet a little bit more closely. It doesn't have to be the ketogenic diet. That is a bit of a problem to institute for our older children.
Okay, great. Thank you so much for that. I think any neurologist would agree that some reduction in seizures is better than none.
Especially so when it comes with improvement in behavior and cognitive ability. Yes. Yeah, for us, hyperactivity in children is a serious problem.
Yeah, and overall functionality. Yeah, definitely.
Yeah.
Okay, so Dr. Samia, thank you so much for an excellent presentation and Q&A session, and thank you to the participants for attending as well as for the questions. I think it's been very informative for everybody. And with that, I'm going to close the session and wish you all a good night or a good day, depending on which part of the world you are in. Okay, so thanks till we meet again.
All right, thank you very much, Dr. Naidu. It was a pleasure running the session with you. Thank you.
Sure, great. Thank you, everyone.
Bye-bye. All right, bye.
Bye.